Now let's proceed to the reactors for this webinar. Let us first introduce to you the first panel of reactor. He is the past chairman of the Committee on Trauma of the Philippine College of Surgeons. He is also the director for Trauma, Injury, and Burn Care Commission and the medical legal consultant of the St. Luke's Medical Center. Let us welcome attorney Professor Joel Macalino.
I thank you very much. Those were excellent lectures. I have a question and a comment for Professor Tercio de Campos. Well, I too am a student of history, so I like looking into things. Now, as regards to damage control surgery, you first mentioned the Pringle maneuver in 1908. Of course, this was followed later on by the works of Anna Ledgerwood. Pringle's maneuver, it's a liver injury, and Anna Ledgerwood, they were actually describing liver injuries. Then, of course, the works of Roy Kahn and Feliciano sometime in the end of 1970s. And then what is important, in the 1980s, 1983, the works of Harlan Stone, which was also mentioned by Professor Yosumitsu, is that they identified they first described coagulopathy. And I think that is the start of damage control resuscitation as opposed to damage control surgery. So again, and then you mentioned the Navy, which is the primary where damage control started. And I think it has been reported that damage control resuscitation is much of a product of the Operation Iraqi Freedom and Enduring Freedom, which is part of the Army, I think the US Army. So now, shifting from damage control surgery towards the more physiological aspects, damage control resuscitation. So looking at your crystal ball, so what will be the newer thing as regards to this development in taking care of the exsanguinating trauma patient?
Thank you very much. That's a very important point. So a long time developing the concept of damage control resuscitation with damage control surgery as well. So it's really hard to decide how can you do that. And right now in 2021, what's the right time to make damage control, and when we decide to make this kind of procedure, we should consider strongly the history of this concept and what happens in the last 40 years. So that's very important, and we should bring all this history right now, so we could have a chance to have a better decision to patients right now when we have damage control situation to act. Recently, we have done a procedure like that, and the most important thing is to decide as soon as possible, to plan as soon as possible. So that's what history teaches us. So if you make that decision as soon as possible, you should have better results. And what happened with a patient here in my hospital, a very severe patient, that we had the opportunity to make this procedure, and patient was well. So I think that's the most important things about
that. Thank you, Dr. Wee, for kind introductions. Congratulations to Dr. Prof. Kenneth for a very excellent presentation. I think it's very concise and very precise and very factual approaches of how to deal with liver trauma, as we well aware that I think liver trauma is one of the I would say considered one of difficult management of trauma, especially for solid organ, because of it come in variable characters rather than just bleeding alone. And I think you had presented very well on the approaches of when dealing with this kind of situation, right from the preoperative assessment, optimizing patient before undergoing surgery, intraoperative assessment, and I think I think even the decisions whether for damage control or definitive repair when come for the decision making for the surgical approaches, and what will be the alternative. Perhaps I just like to highlight, or probably you, perhaps if Prof. Kenneth can we highlight again a few things probably I would just to bring in based on the discussions or question that has been given along the presentation. One question that I would like to ask to Prof. Kenneth with regards to nowadays, I think when I think in the textbooks of when dealing with liver surgery or liver trauma, the decision between conservative and surgical interventions, I think how do we judge that decision? Is it just based on the clinical parameters of exsanguinating patients? And with regards to the role of CT scan, where do we go? Because nowadays, I think it tends to be a trend among the young practitioners or young surgeons where I think any particular traumas, especially dealing with the abdominal injuries, I think they always insisted of CT scan for evaluations of the liver injuries. So perhaps you can proceed with that opinion before I move to another questions. Kenneth, back to you.
Yeah, thanks a lot. Thanks for the question, Rosman. I'll start off by talking about the CT scan, which is what you mentioned. The CT scan is very helpful. It's got a high sensitivity and specificity in patients who are hemodynamically stable, not in shock, and allows us to characterize where the injuries are and how severe the injuries are. But it's important to also remember it is not the grade of injury you see that determines whether you operate or manage a patient conservatively. It's actually whether there's bleeding, the degree of physiologic compromise that your patient has that will influence your decision making. So if you see a patient who has a grade 1, 2 liver injury, chances are this patient is going to be managed conservatively and you are very likely to get excellent results. If you're a patient who's got a grade 3, grade 4 injury, selectively, some of these patients can still be managed non-operatively, but the chances are higher that you will fail with non-operative management as you get with higher grades. But it's not the injury per se, it's whether or not it's associated with significant bleeding and whether or not that gives rise to physiologic compromise that often is the trigger for bringing a patient to surgery. So I don't just look at the anatomic injury, I look at the clinical condition of the patient to determine whether the patient is physiologically challenged and whether the patient actually now is on that slippery slope going further down because of uncontrolled bleeding that's driving this physiologic compromise. And if that were the case, I have a lower threshold for managing this patient more aggressively. In the chat group, we talked about the influence of multiple organs. And yes, while each individual organ might influence your decision whether to operate or not, and as long as any of the injuries warrant urgent operative repair, then your entire strategy for non-operative management fails, and you have to bring your patient for surgery. But certain combinations of injuries may lower your threshold and make you more predisposed to a more aggressive operative repair. And the example I gave was when you've got a concurrent severe head injury, and you may not want to compromise on cerebral perfusion by leaving it to chance, to wait to see whether or not the patient then decompensates with further ongoing bleeding that's actually taking place. There are also interventions that may push you towards being a lot more confident to wait it out, and that's if you have the opportunity to carry out angiography, embolization, and you have available facilities that allow you to manage coagulopathy very aggressively. And these may push you towards delaying a decision to operate. Remember, with each organ that's injured, with each organ having bleeding and swelling, it also increases the risk of abdominal compartment syndrome arising. And that in itself can be a trigger for bringing a patient to theater for a decompressive laparotomy and to control bleeding secondarily.
Thank you, Kenneth. I totally agree with you. I think the role of radiology imaging, particularly CT scans, and to add, it is sometimes also beneficial, especially those in grade 2 or grade 3, even grade 4, because sometimes you do have some background assessment of the liver anatomy. If at any point of time that you need to go in, at least you have some kind of mapping of what you're going to encounter during the surgery. The next questions, I think, will be regards to a very simple question that I think it may be in your presentation, but Prof. I hope you can highlight it again. We agree that I think liver bleeding is very obvious that we have to take care whether it's definitive or damage control. But sometimes you do have a concomitant bile leakage during the exploration. So what's the best ways how to handle this kind of bile leakage? Because sometimes this may intrigued or sometimes affect your judgment and eventually delaying your treatment strategy and hence affecting the patient outcome.
Thanks. I'll have to say that in the order of priorities, bleeding trumps bile leaks. So bleeding can give rise to exsanguination and your patient can die from that. So that's your priority for treating it. If at the initial surgery, you see just a little bit of bile leak, you put a gauze on a raw surface and comes out with a little bit of a yellow stain, you know there may be a leak there. You can actually see an obvious spot, and if it's not too difficult to place, just a single stitch to control that, you may go ahead and do it. But I'm not going to chase for a bile leak. In that sort of situation with a minor leak, I'm prepared to accept that, pack the liver, and come back another day where the patient is better resuscitated physically, and reassess the situation whether an ongoing bile leak is still present. Remember that minor bile leaks often stop spontaneously on their own and therefore may not actually require further interventions. And this is particularly if there's no obstruction to bile drainage. And if that were the case, a lot of times these minor leaks will settle. But there are severe leaks that will not settle conservatively. You've got a torn gallbladder in front of you. You've got to actually manage that injury definitively, and that may require a cholecystectomy. If you've got a very unstable patient and you clearly can see a rent in the CBD giving rise to significant bile leak, you may temporarily control that, converting that into a controlled fistula with a T-tube, but then consider doing definitive repair when your patient is optimized and at that second surgery. So the first surgery, don't do anything definitive, just control bleeding, manage contamination, get out, give the chance for your intensivist and anesthetist to improve the physiologic situation for your patient, and think about coming back a second time to carry out any definitive repair.
And finally, last questions. I think with regard to definitive surgical repairs following our damage control, I think because I think when we had deal with the bleeding itself and then subsequent going in for the damage control approach of definitive repairs, in what situation that you think that the surgeon as a generalist are able to handle, or in what situation that you think that you need more experienced seniors or hepatobiliary surgeons to come in together rather than going in without doing anything especially for the junior surgeon? What would be your advice in terms of their preparation on this?
Well, as you know, I'm a HPB surgeon, so I'm a little bit biased here as well, just as I do trauma surgery. But I will say that a well-trained general surgeon already has many skills that allows him to manage many injuries in the liver. And the majority of liver injuries, in fact, still continue to be mild injuries. And with the basic principles we described earlier, with confidence and be able to do this, in fact, many general surgeons can manage these injuries competently and safely. But it's the more severe injuries that are more problematic. The complex injuries, grade 4, grade 5 injuries are less accessible behind the liver, particularly involving juxtahepatic venous injuries. These are more complicated injuries, and often these are not situations that the average general surgeon would deal with. In fact, the area behind the liver and the area extending down to the pancreatic head is tiger territory and often a nightmare for many general surgeons who are not familiar with those areas. And where you're dealing with injury that shakes your confidence, goes beyond what your normal experience is, it's always a good idea to get someone more experienced to go in with you, and that may very well be a hepatobiliary surgeon. Bear in mind, many hepatobiliary surgeons don't manage trauma. And in fact, the hepatobiliary surgeon often is disadvantaged when carrying out damage control surgery because his ego sometimes may get in the way. And he's always wanting to dive deeper, do something about that little bleed that's present, while the clock is ticking, the patients are getting more and more physiologically challenged. And the general surgeon here sometimes has the advantage of seeing the forest instead of the trees, And it's a responsibility of general surgeon then to hold back the liver surgeon and prevent the liver surgeon from causing more harm to the patient.
Thank you very much, Professor Hermine. Now let's proceed to our next panel of reactor to give his reaction to Professor Schultz Baloch, the past president of Hong Kong College of Emergency Medicine. He is also the chief of service of the Department of Accident and Emergency, Queen Elizabeth Hospital in Hong Kong. Let us welcome Professor Ho Yu Fai.
Hello, everyone. I'm particularly interested in the management of excoriating pelvic fracture, which we do have some experience in Hong Kong. Our experience is that angioembolization alone is not very effective in stopping bleeding for those patients really hemodynamically unstable. Rather, we have very difficult situations in a very unstable patient to decide where the patient's bleeding coming from. It's from bone, from the venous side, or from the arterial side. So I'm just asking Professor Baloch whether you have any case selection criteria on how to judge which patient is bleeding from which site predominantly, arterial, venous, or the bone, so that we can treat the bleeding in the target situations.
Well, thank you very much. It's very, very relevant. I think venous bleeding from pelvic fractures, in closed pelvic fractures, is self-limiting. If you are able to close the pelvic ring and provide hemostatic resuscitation, then venous bleeding just doesn't have anywhere to go. It's it's less than 20 millimeters in mercury, low pressure system in a closed space. It cannot really expand, and not for hemodynamic instability. The reason why we had this problem in the past, because patients came with pelvic fractures which haven't been bound, and they were loaded with crystalloids, and they were in a coagulopathic state, and they were bleeding from everywhere. Now today, what we see that anybody who, after binding and a couple of units of blood and plasma, whoever is still elicit hemodynamic instability, those have pelvic arterial bleeding or the blood losses from somewhere else. So basically, we haven't lost any patients during the last 15 years who didn't have arterial bleeding. So my answer is the patient hemodynamics is most important, and what sort of measures you have done. Closed pelvic ring, proper resuscitation, still hemodynamic instability, it's arterial bleeding, and best to manage with embolization. And it's very well supported by the packing data. If you start packing everybody who comes through the door and potentially hemodynamically compromised, you end up with 15 persons needing an angio. And my argument is that those are the ones who would need angio at the first place because they're having arterial bleeding. In terms of bony bleeding, again, there tend to be capillaries and small arteries. For them also, your best shot is closing the ring, binding the pelvis, and provide hemostatic resuscitation.
Okay, so how about the strategy of trying to do all in damage control type, like packing, fix the pelvis with an external fissure, and followed by the packing and then angio, or the reverse, or angio first followed by packing. That means in one go you try to stop all the potential sites of bleeding. But if you have any delay in summoning your radiologist to come in to angio the embolization, using the rebore to buy some time to plug the aorta so as to stop the arterial bleeding for a while. So what do you think this approach, which we call in Hong Kong 3-in-1 approach? That means external fissure, pelvic packing together with angio embolizations for those patients with really hemodynamically unstable patients, so without a chance of doing the imaging to determine where is the site of bleeding. We did in the past 8 to 10 years, we tried to do this approach, and we successfully decreased the mortality from around 60% for exsanguinating vegetables to around 20%. So it seems that is we didn't do any harm, but we also didn't wait till the patients deteriorate further to decide which to go for among those three strategies. So this is something I'm always have a clear in mind, whether we should do it sequentially or we do it in one go. So you know, your experience that you don't pack it, you fix the pelvis by pelvic binder and then give the fluid and then, but if the patient deteriorates further, you go for embolization. So this is your approach. And what would you think the approach that we have been practicing in Hong Kong? Are we doing something redundant?
Well, I think the literature shows that whatever protocol you use and you systematically pay attention to it, you're gonna improve your outcomes.
Okay.
20%, and you know that's been shown in any protocols. 20% mortality to me is still a bit too high. That means one in 5 patients who come to the door with hemodynamic instability with pelvic fracture. That's I think it's a little bit too high. But you know, you can have potentially more severe injured patients and combination of head injury or whatever. But I would say that external fixator in an acute setting doesn't do more than a pelvic binder. So to me, that's a waste of time and just distracts your focus. And I understand that in some institutions have the radiologist a little bit late to come in. But if the radiologist late to come in, you cannot keep up the reservoir for so long either. So then you inflate the reservoir and leaving on and off. And so then again, I think we need to make sure that the angiography is done as fast as you would do a trauma laparotomy, because that should be a standard, because it's a hemorrhage control measure and it needs to be fast. And they have to accept that sometimes they come in unnecessarily. Like we go to a trauma resuscitation and sometimes just a sprained neck, and not everybody bleeding, which we attend to in the resuscitation bay. So I think your protocol obviously working. I would just aim for a faster angio, because that's good for everything else. Once you have a fast responding angio service, that's not just for pelvic fracture. That's good for liver, good for parenchymal injuries in the abdomen, good for maxillofacial injuries, good for potential cerebrovascular and junctional trauma. So once you have a well-responding angiography service, then you got lots of ability to utilize that. If you de-skill these people and you say that I'm just packing all these pelvic fractures, then you end up with a problem that they're not gonna respond you fast for other problems as well. So that's my approach in a big trauma center like yours, that yeah, these guys has to be as fast as we are in surgery.
Yes. I think there will be various protocol available, depends on the availability of your specialists, whether they are in-house or where the response time is quick enough to come back to stop the hemorrhage. So this is the limitation in our hospital, and probably in some of those in other regions, that we might choose another protocol to just to buy some time, and so that the appropriate person can come in to stop the bleeding, which unfortunately this kind of bleeding, unfortunately this kind of injury is not happen that frequent in our hospital. We have around maybe 15 to 20 cases a year. So it's really difficult for us, according to our financing situations, to keep our radiologists, intervention radiologists in-house 24 hours, 365 days a year. So this is our limitation. I hope that there will be other ways that we can try to save these kind of patients when the resources has constrained and limited. But I enjoy your lecture very much, and it did show that there is an alternative way of managing patient if you have the resources. Thank you very much.
What is the role of a diagnostic laparoscopy for suspected small bowel injury and trauma?
Thank you very much for your question. I think your question is about the role of the endoscopy operation in the small bowel injury. I think it is not good for the endoscopic surgery when the patient is in the jejunal injury, because it is hard to find out the injury site in the hemorrhagic abdomen, and sometimes you will miss the injury, and it is not easy to repair when you find out the holes in the jejunum. You have to open small abdominal site to suture the abdomen, not under the endoscopic suture. So I think in the trauma patient who had a blunt or penetrating abdominal injuries and suspected the small bowel injury, I think the endoscopic surgery is not prompt, and I recommend to do the open surgery in this patient.
Thank you, Professor. That was a good answer, actually. But for my second question, I'd like to ask about blunt trauma. And what you see on a CT scan, for example, would be a large small bowel mesenteric hematoma. In the event that there is a blush on the CT scan in this small bowel mesentery, would you say that there will be any role for embolization in number one? And number two would be, if there was a large hematoma in the small bowel mesentery, but there was no blush, would you still go in for laparotomy to assess the viability of the bowel or treat this conservatively?
Thank you very much. And for the first question about the do the angiography for the brushed image on the CT scan, I think angiography for the jejunum or hollow viscous injury is not so big role, and I think the hemostatic status is very important to decide the strategy. And if it's stable, we can have a observation, no operative management. But circulatory status is unstable, we have to do the open surgery, not the angiography. And second question, if there is non-brush image.
There's no brush image, but there's a large expanding or large hematoma in a small bowel mesentery. Would there be a role for either diagnostic laparoscopy or laparotomy to assess a small bowel viability? Or would you just, as you said just now, observe clinically and see whether the patient gets better?
Examination of the abdomen every 4 hours. And if there is some signs of peritonitis, we do the open laparotomy.